Good evening. I'm Dr. Dan Fortenbacher, founder of Wild Vision Therapy. Let me say what a pleasure it is to welcome you to the first episode in our series of the Luminary Program brought to you by Wild Vision Therapy, dedicated to advancing awareness and understanding of developmental vision and neuro-optometric vision rehabilitation. Now, our first episode is entitled The Effects of Binocular Vision Dysfunction on Socio-Emotional Development by our very own Dr. Alyssa Pars. Dr. Pars is a partner and clinic director of Wild Vision Therapy, Grand Rapids, and treats patients in Grand Rapids and West Michigan area. In 2015, she received her Doctor of Optometry degree, summa cum laude, with the highest distinction from the Illinois College of Optometry. In 2016, she completed a residency in developmental vision and rehabilitation to the Southern College of Optometry Private Practice Residency Program at the highly recognized Drayson Vision Group in Charleston, South Carolina. She is a board-certified fellow of the College of Optometrists in Vision Development, and it is indeed my pleasure to introduce Dr. Alyssa Pars.
Thank you so much, Dr. Dan. I'm excited to give this presentation tonight on a topic that's pretty near and dear to my heart.
Well, that's actually starts an interesting question. Why don't you tell us a little bit about what's inspired you to write and lecture on this topic?
So this presentation really came from, honestly, just listening to my patients coming in the office. You know, our office, we specialize in patients that have developmental vision delays, traumatic brain injuries, and while it's so rewarding to help them to, develop depth perception for the first time or, help get a more stable visual system, something that I don't think a lot of people think about is how much of a mental toll those delays can have on a patient. And what I'm hearing from patients is things like anxiety, depression, low self-confidence, really being affected because of the visual system that they really just cannot trust. And I want to be able to get that information out there that, we have to treat the whole person, not just the visual system. And it's really important to provide that information and then also give these patients resources so that we can, help in all of these areas.
Oh, that sounds great. Well, with that being said, how about we get started?
All right, sounds good. I'm going to share my screen now. Okay, so as Dr. Fortenbacher said, the title of my presentation is The Effects of Binocular Vision Dysfunctions on Socio-Emotional Development. And I already touched on this a little bit, but some of the things that I hear from patients and parents coming into the office for their initial exams are things like I have listed here, where they say, my child is so anxious during school days, they're sent home with stomach aches and headaches. My child's very emotional on school days, angry, crying, and on the weekends, it's a totally different kid. They might be getting bullied in school due to an eye that's actually turning, struggles with attention and concentration, but very specific struggles where, it's only when they're sitting down to do a near task, reading or something like that, that attention becomes an issue. And then I see the adults that are reporting low self-confidence in the workplace and with friends and family, anxiety in busy environments while driving, grocery stores, and even depression, definitely, in patients that have double vision. That's especially true, I'd say, in my patient population of post-concussion vision syndrome and stroke patients. So that's really, where this presentation came from, is hearing this over and over and over again from my patients and wanting to make sure that, yes, I'm here to help them, but other resources are out there and helping to get that, widely accepted in general. And so I wanted to start this presentation first just with some of the statistics. And these CDC statistics come from 2016. So I would definitely argue when the new statistics come out post-COVID, these will probably all go up based on what I'm seeing in the office. So ones that I focused on were ADHD, anxiety, and depression. In children ages 3 to 17, the prevalence of ADHD is about 9.8%, anxiety 9.4%, and then depression 4.4%. And then in adults, we're seeing anxiety with the population of about 11.7% and depression about 4.8%. So that's just kind of an overview on statistics. But then when we talk about what are some of the visual diagnoses that can affect quality of life, and you can see this is a long list, pretty much every diagnosis that we treat in the office, because there's a huge range of these diagnoses that can absolutely impact quality of life. Everything from strabismus and amblyopia to the more vision and learning conditions like convergence insufficiency or divergence insufficiency, accommodative dysfunction, ocular motor dysfunction, a post-concussion issue, and then visual processing delays, which of course that can be layered in on top of any of those other diagnoses. So, big picture, all of these visual diagnoses can absolutely have a major impact on people's overall mental health, and that's, something that we really need to remember. And why is vision such an important quality of life factor? So we have to remember that vision, it's more than just eyesight. So it's a process. It requires the skillful input of visual information, the processing then of that information, and then finally integrating it with the other sensory systems. And that's vestibular, cognition, auditory. You have to be able to integrate your visual system with all of those other areas in order to really be effective and, get around your environment. So here's just a little breakdown of when we say we're looking at eyesight versus vision. Eyesight is the measurement of how clearly we can see at a very specific distance, usually 20 feet away and then 16 inches at near. So that would include nearsighted, farsighted, astigmatism, but we have to remember in our everyday life, things are not set at those very specific distances. So you can absolutely have blurry vision, but not be nearsighted or farsighted or have astigmatism, but that blur coming from something else like the accommodative system or poor eye teaming abilities. So that's where we go beyond just eyesight and look at vision. And when we're talking about vision, that means how well are the eyes teaming together and focusing? How well do they track across the page or in space? What's the patient's depth perception like in peripheral awareness? And then their visual processing skills. And you can see the list of different areas of visual processing that we are looking at. And then remember, 80% of the neurological pathways in the brain connect with the visual system. And how do binocular vision dysfunctions affect social-emotional development? Well, mental disorders, they happen in the brain. And we know, like we said, 40% of the brain at least is involved in visual machinery. Commonly, we see patients that not only struggle with vision problems, but they also have mental health concerns. And I really like this quote from Dr. John Streff that says, "When vision's working well, it guides and leads. When not, it's interfering." When it's interfering, that's throwing our body into fight or flight mode. It's high stress. There's lots of compensations that are being made. So I think that quote could not be more true. Now to focus on some of the common mental health disorders that we're seeing with binocular vision dysfunctions. And those include ADHD, anxiety, and depression are the ones that I focused on for this presentation. ADHD, about 6.1 million kids have been diagnosed with ADHD, and the statistics are kind of staggering to me because 388,000 kids aged 2 to 5 are being diagnosed with ADHD, 2.4 million aged 6 to 11, and 3.3 million aged 12 to 17. According to the 2016 CDC Parent Survey, 6 in 10 kids with ADHD also had another mental, emotional, or behavioral disorder. And I see this a lot in our office where the child has been diagnosed ADD or ADHD, but also has significant anxiety and is now on multiple medications, or also has a behavior and conduct diagnosis that is interwoven with this ADHD diagnosis. But how do we know if it's really ADHD or could it be an underlying binocular vision issue? I pulled this really nice table from a book I love, what's written by Wendy Rosen called The Hidden Link Between Vision and Learning. And ADHD is the most common misdiagnosis in patients that have convergence insufficiency. And that's true because there's such a big overlap in the symptoms. And that's what this table is showing. 15 of the 18 symptoms that are linked with ADHD are also associated with a binocular vision dysfunction. So it's really common that it's truly a binocular vision issue and not actually ADD, not in all cases, but it's definitely playing a role. So it's something that in our office, we're also tracking patients' attention and concentration. We have a checklist that we have parents fill out for their child, tracking those different symptoms on the ADD symptom survey. And then we watch as their visual system gets more stable, how those symptoms are changing. Now, anxiety, this is just the definition. It's a feeling of worry, nervousness, or unease, typically about an imminent event or something with an uncertain outcome. In order to be truly diagnosed with anxiety, you have to have 3 or more of the following 6 symptoms in more days than not over the past 6 months. And that's for an adult. So those 6 areas are restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. But for children, you only have to have one of these areas to be diagnosed with anxiety. It's the most common mental illness in the US, affecting 40 million adults over the age of 18, and occurs more commonly in women than men. Now, what are some of the symptoms that can be occurring when someone has anxiety? These are three really common ones that we're seeing, including tunnel vision, light sensitivity, and blurry vision. So going into a little bit more on that, tunnel vision really is looking a big area that is affected by anxiety. It's causing a reduced peripheral awareness. You're in fight or flight mode, so you're hyper-focused on what's happening straight ahead of you. It leads to poor spatial awareness. So now you're bumping into things more often, clumsy. If you're reading something, you tend to lose your place even more frequently because now you're looking out of a really tiny window functionally. So it magnifies even any underlying binocular vision issue that's present because that peripheral awareness acts as a lock. And now you're lacking that. So, if you're already having, blur, double, something like that, it tends to only get worse once you get into this mode. Light sensitivity is another big one that we see, and that's coming from the sympathetic system being overstimulated. It actually causes the pupils to dilate, and you become uncomfortable in bright light, which for a lot of patients we'll recommend tints for to help decrease that light sensitivity. Exploring different levels of tints can be really helpful. And then blurry vision, which stems from a decrease in the focusing system strength, the accommodative system, causes a pupillary dysfunction, which makes it harder then for the eyes to accommodate at near and relax their focus then into the distance, causing that blurry vision where even though a patient might have 20/20 eyesight or not have, a prescription present, they're still reporting this blurry vision that comes and goes. And if they look long enough and focus harder, it can eventually become clear, but it's definitely not automatic. And then now looking at depression, which is a medical condition in which a person feels very sad and anxious, and there's also physical symptoms. Here's just a list, and it goes from mild to severe of some of the symptoms: feeling sad, a loss of interest in pleasure activities, changes in appetite, trouble sleeping, loss of energy, feeling worthless or guilty, difficulty thinking, and then thoughts of death or suicide. For depression, there's 1 in 6 people that will experience depression at some point in their life. Again, women being more affected than men. And there's a high heritability, about 40% when a first-degree relative has depression. And I think that's really important to remember too, because you're not just treating the patient in front of you. The whole family becomes involved in the case. And so just thinking about that, making sure, talking to family members, there could be a level of depression even within family members too. And one of the biggest things in patients with depression that we see is an overall reduced contrast sensitivity. So literally the world looking dimmer, less bright, which again is where we'll utilize sometimes tints to potentially help increase that and make things, easier when they're looking and better contrast in general. And now going into one area, so I have this broken down kind of into different sections. This first one is about vision and learning and how underlying vision and learning struggles from the visual system can cause some of those anxiety, depression, self-confidence issues. So we'll start here. These conditions are often unrecognized, yet the vision problems affect the child's reading and learning. It affects a significant percentage of kids ages 6 to 18. You can see the stat off to the side, 1 in 10 have a vision and learning problem. It occurs equally in boys and girls and impacts reading performance. It's often associated with behavioral problems too. And these kids typically have 20/20 eyesight. Really important in these cases is seeing past the labels. These kiddos are the ones that a lot of times are just getting labeled right off the bat that they're lazy, they're just distracted, they have poor attention, they're trying to cause a behavior issue, or they're a class clown. But we have to think about what's the underlying cause for them acting out in the classroom. And that's really what I'm going after to see, what can I do? What is their visual system doing? Is it not working efficiently? And then now they're struggling to focus up close or, get really distracted when the room becomes louder. And these parents often report that homework too is a huge battle, especially at the end of the day when their visual systems are tired. They're losing their place easily, reversing letters and numbers, have poor concentration and memory, copy poorly, so poor spacing, it's not on the line, and homework assignments take a lot longer to complete. During a reading task, a child with a vision-related learning problem will typically struggle even though they're really bright. They may need to use their finger, be really reliant on that, or use a highlighter strip or marker to keep their place. It tends to get worse as the print gets smaller, like chapter books. So in our office, a lot of times when these diagnoses are being picked up, we love to see it in, when we can help right away in a kindergartner or first grader. But more commonly, I would say one of the biggest groups of patients we're seeing is those third, fourth, and then fifth graders where, they may have had these diagnoses when they were younger, but they were able to compensate for it then because the print was larger, it was more spaced out. And now the demand for reading has gone up and everything is smaller. Now they start to struggle more. So just keep that in mind. These kids also miscall easy words that we know that they know, like things like this or the, and sometimes can adopt an unusual head posture or tilt, especially if they're noting double vision. They'll really tilt their head to try to eliminate the double image or cover an eye. And that's always something we're looking for when we're doing testing with patients. Here's just another little overview, some of the symptoms. I talked about most of these already. Trouble recalling easy words, trouble with paper pencil tasks, copying from the board taking a longer time, headaches, blur, double vision, all of those areas. And then these are the top 3 diagnoses when we're talking about a vision-related learning problem. First is convergence insufficiency, which you can see the little example there that we have in some of our brochures to help demonstrate, are you seeing like this when you're looking at something? It's really nice to have a little demo to show a child and then be able to show mom or dad that, hey, this is how they're seeing and this is why it might be more difficult for them. The other diagnosis is ocular motor dysfunction. So words looking like they move around on the page. I had a patient once that told me it looked like words ran on the page. They ran all over the place. And once he did some vision therapy and he was at his first progress checkup, I asked him about that again. And he told me, oh, no, they just walk around the page. They're moving slower. And then he was so excited to tell me about the second progress checkup that the words finally stopped moving. And so now it's way easier for him to read because they're not constantly moving all over the place. So that's a really big one that affects these patients. And then accommodative dysfunction, which is that blurry vision, especially when they're doing a task like copying board to paper. This one can affect things because it's blurry and it takes some time, extra time to make something clear. So convergence insufficiency, it's the inability to coordinate the eyes together as a team. About 5 to 8% of people in the US have it. Symptoms for convergence insufficiency can range from eye strain and fatigue and to blur and double vision. It's also, like we talked about, related to poor attention and concentration. And sometimes it gets to the point where they're just so frustrated. Now the child's just completely avoiding reading or just completely going based off of audiobooks and, eliminating the visual component. So it's always something I ask about. Do they enjoy reading? And then what are they reading? Is it just a graphic novel? Are they actually reading by hearing it? Because you really want to understand what that child's doing. And here's again the symptoms that are related to it. And how do we test for it? So one of the biggest things and best tests we have is the near point of convergence test. This measures the strength of the patient's ability to cross their eyes at near. The test itself, we do the red-green pen light near point of convergence test because it's a really pure convergence test. If you use a small little letter target, then the patient can activate their accommodative system. So in kids that have a strong accommodative system, a lot of times that near point is closer than what it really is because they're activating accommodation. So that's why we prefer to use the red-green pen light test. And what you're doing, the patient wears red-green glasses, you're holding a pen light or a transilluminator, slowly bring it closer to the patient's nose and ask them when it goes double and they see 2 separate lights. We repeat this test always 3 times because we want to see what happens as their system gets more tired. And seeing 2 lights greater than 2 to 3 inches from the nose indicates convergence insufficiency. Now for accommodative dysfunction, that's the inability to focus the eyes for concentrated reading or shift focus from near to far. Symptoms can go from blurry vision, headaches, again, poor attention, and misidentifying familiar words. And again, here's symptoms listed. One of the tests that we use, so you can check for accommodative amplitudes. Also the NRA, PRA, MEM are all great accommodative tests. I highlighted one we like a lot in office, which is the plus and minus flipper lenses. It's a nice, quick and easy test and tends to be one that's more easily understood, I would say. So the patient's holding a plus and minus 2 lens looking at a near target. and you hold those lenses up in front of them and they tell you as soon as they can make it clear, and you're flipping back and forth. The goal is for them to be able to clear both the +2 and -2 sides in 1 to 2 seconds. If they cannot do that, then that is significant and can be accommodative dysfunction. And then finally, ocular motor dysfunction. I talked about the example with my patient of words running around the page. It's the inability to point the eyes on printed material and skillfully move them from word to word through the rows. So these patients losing their place often, rereading, skipping over words. It can lead to poor reading fluency, even affects their reading comprehension. Because this is a visual skill, it should be a tool in their toolkit for reading. When it's not, that's when these patients are starting to struggle, and so it can be harder to actually remember the content of what they're reading. And then they lose attention also. About this. One thing I didn't mention though too is don't forget that there's also the pursuit eye movement. So tracking the ball in sports like baseball is another big area you want to look at, and that's what this next test is assessing. So smooth pursuits. This one we have a little near target. We're slowly moving the target, having the patient watch the target. We use a little bead on a stick. It doesn't have to be anything super fancy for that. And the really important part with this one is not only do we test it when they're totally focused on the task, but we also do it when we are asking easy questions, because we want to see, is this system automatic, or do they really have to put all of their attention on it in order for them to do the task? And we know real life is going to be filled with distractors, so we want them to be able to handle it at that level. So as I'm moving it, I'll coach the patient and say, okay, now I'm going to ask you some easy questions while you follow the bead. And I don't try to trick them. It's very simple. Just what's your favorite color? What's your favorite food? Do you have any pets? And I instruct them, don't look at me, keep watching the bead as best you can. And in many, many patients, if they passed the test when they're totally focused on it, they really struggle as soon as you add that cognitive component to things. And that's what I'm noting. The other test you can do for tracking is the Kindevic eye movement test. And you can also do a double bead saccade, where it's 2 different colored beads and they're jumping back and forth as you call out what color to look at, and you're watching how accurate their eye movements are. And then the next area is, of course, visual processing delays. So difficulty processing the information that the child is seeing. These symptoms include things like the frequent letter and number reversals, poor eye-hand coordination, mixing up the order of letters in words, so switching things like was to saw or who to how. Poor memory, so spelling words maybe being really challenging, remembering lists or directions. Difficulty making sense of a cluttered environment. That could be a busy grocery store shelf, driving, making sense of clutter, their busy worksheet in school. So that's a really big one that can affect things. These are all the tests that we look at for visual processing. So you've got the saccadic eye movements, visual discrimination, memory, sequential memory, spatial relationships, figure ground, and visual closure. Also left-right awareness, letter reversals, and eye-hand coordination. So that's kind of the vision and learning side to this. The next area I'm going to focus on is patients with strabismus and amblyopia. So strabismus, it occurs in about 4% of the population. Infantile esotropia is the most common type of strabismus in babies. Accommodative esotropia is the most common type in kids over the age of 2. And something interesting to know is there's a 14 times greater risk of having strabismus in premature infants, less than 2,000 grams. Low APGAR scores and a family history of strabismus also increase the risk of developing it. Amblyopia, or more commonly known as lazy eye, it's the most common cause of vision loss in kids. This is when, with best correction, glasses or contacts, the patient's unable to see 20/20. And the most common causes are an eye turn that's constant or very, very high frequency, and a high prescription, either in one eye or both eyes if it's a bilateral amblyopia. Of course, there's also deprivation amblyopia, but the other two are the more common reasons. And the prevalence here is up to 1 in 30 kids have amblyopia. And now, what's the effect of strabismus on mental health? And that's why I really did kind of a deep dive into the research on these areas. And I was really surprised to see there is a ton of great research out there showing this connection between mental health and strabismus. So I have a list at the end of this presentation with some of the research I found, but there's definitely lots of great stuff out there, and I wanted to highlight some of those. So recent studies show that children with some exotropia and congenital esotropia have a 3 times increased risk of developing mental illness by early adulthood compared to the controls in the studies. Adults with strabismus have a 27% higher risk of a musculoskeletal injury from a fall, I assume because of the poor depth perception there. Adults with strabismus encounter negative psychosocial effects and report difficulties in employment, relationships, and self-image. So here's one study that was done. It's the prevalence of mental health illness among patients with adult onset strabismus. And this study found that adults with divergence insufficiency were significantly more likely to develop a psychiatric related hospitalization and psychotropic medication use than the controls. It was interesting to me in this case, it was the divergence insufficiency cases that had a significantly higher number of unspecified anxiety disorders, and adults with small angle hypertropia, which a lot of times that's not even something yet we cosmetically see, have a mild increase even in specific mental health disorders compared to the controls there. So why do we see so many patients with strabismus have anxiety, depression, and low self-confidence? And that's where I, again, dived into the research here. So here's the negative social bias against children with strabismus. And the purpose of this study was to determine if an eye turn in children affects teachers' perception of the child's personal characteristics. In the study, how it was done, there was photographs of 2 boys and 2 girls, and they digitally altered the photos to create it so the same child had an eye turn inward, outward, and then had straight eyes. And then they asked elementary school teachers to rate the perceptions of the children's personal characteristics based on their responses to those whole face photos. And the participants were also asked to answer 5 questions related to their first impressions based just off of the photos. So here's an example of what the photo would look like. You can see the child on the left has straight eyes, in the middle an eye turn in, and the end an eye turn out. So this is what the teachers looked at. And here's an overview of some of the questions they asked these teachers. 1 was, would you assign the student to a duty during cultural activities in school? 2, would you take special precautions to prevent the student from cheating during a test? 3, can the student be accepted into a social group of friends? 4, would the student have any difficulty in learning? And then 5, can the student fulfill the responsibilities given to him or her? And they also judged them based on characteristics, and they scaled it. 1 would be the lowest and 5 is the highest. Characteristics were intelligence, health, trustworthiness, hardworking, happiness, cuteness, hesitancy, aggressiveness, activeness, and sentimentality. And the results from this study were pretty shocking to me because children with an inward or outward eye turn were rated more negatively than the kids with straight eyes on literally all 10 characteristics. In this study, the children with an eye turn in were rated more negatively in terms of their score than those with an outward eye turn on most of the characteristics. So in this case, it was those esotropes that really were affected the most, but the exotropes still too, compared to the controls, were absolutely being judged more negatively. And to me, I thought about this of, I think of the children, other kids in the classroom, maybe making those judgments, but to also know that it's happening from the teacher's perspective is something to really, take to heart. This is another study. This was in adults now. So it's the negative psychosocial impact of strabismus in adult patients. The purpose of the study was designed to determine if there was a negative social bias against adults with an eye turn that could affect interpersonal relationships and then also limit employment opportunities. In the study, a person with no eye turn was photographed looking in different gazes. And then similar to the other study, they digitally altered the photo to give the patient an eye turn. And subjects were then asked to evaluate a single photograph with reference to personality characteristics that would be important for social interaction and employment capability. And the results here, kind of similar to the other one, but now in adults, is the faces with an eye turn were judged significantly more negatively across all 11 descriptive characteristics than the ones with no turn. The effect of an eye turn in was worse than out again. So esotropia, again, being the one that was the most negatively impacted. And then here's another one. This is the mental illness in young adults who had strabismus as children. Here, they found that children with an outward eye turn, so now it's a little bit different. The other 2 studies, it was the esotropes, now it's the exotropes, had a 3.1 times more likely to develop a psychiatric disorder. Patients with an intermittent eye turn out were significantly more likely to have greater numbers of mental health disorders, emergency room visits, hospitalizations, and then the suicidal or homicidal ideation. Children diagnosed as having strabismus in this population, especially with the outward turn, were at increased risk for developing mental illness by early adulthood. And here's just some of the statistics on that, of the number of patients that went to the hospital, emergency room visits, etc. And now switching gears to amblyopia, and what's the effect of amblyopia on mental health? So this study is the psychosocial effects of amblyopia study. It's to assess the psychosocial effects of growing up with and living with amblyopia to determine whether patients with amblyopia encounter a psychosocial problem. How it was done was a 20-point question survey that was focused on medical background, education, self-image, history of amblyopia and treatment, the effects of amblyopia on work, school, friendships, and self-esteem. In addition, patients were evaluated on somatization, OCD, interpersonal sensitivity, depression, and anxiety. And the results of this study showed that patients with amblyopia as a whole had a greater degree of somatization, OCD behavior, interpersonal sensitivity, depression, and anxiety compared to the controls. So across the board, patients with amblyopia had a much higher degree of some of these mental health issues. A significant number of patients felt that amblyopia interfered with school, which was 52%, work 48%, and lifestyle 50%, which to me is really, really significant. And now that we know those facts, that there's this bias against patients with strabismus and amblyopia and how mental health can really be impacted, and no matter what the case, what can we do to help these patients? So first off, I think it really does take a multidisciplinary team approach. It's first their optometrist going in and identifying the problem, being a listening ear and providing information, whether that's a young child and the parents are telling you that they're really struggling with reading or having outbursts at school, to the adults that have always had strabismus or amblyopia and just thought there was nothing else that they could do because they're outside of this critical period that we used to think was true. Just telling them, no, you can still do something about this. My oldest patient that I treated successfully in vision therapy so far was 87, and she did fantastic. So, giving them hope and the knowledge that there is something still that they can do is really, really important. So that's step one. Then we, as developmental optometrists doing vision therapy to help with the underlying instability of the visual system is important. Helping to plug them in, as we now know, there's a much higher prevalence of mental health issues in this group of patients. So giving them resources for talk therapists, counselors, psychiatrists. If it's a traumatic brain injury case, helping to provide resources for PT, OT, and speech is also really, really helpful. And how do we treat them in vision therapy? Vision therapy, it's brain therapy. It's not about strengthening muscles. It's based on neuroplasticity. Once those new neural pathways are created in therapy, they then can last long term. And this neuroplasticity is the reason that you can get absolutely excellent outcomes in even adult patients, because you're still able to create those new neural pathways at any age. There's three key concepts for effective vision therapy. The beginning being awareness, helping the patient be aware of when their eye is turning or when it gets blurry or double. We first have to help them be, in tune that that's even occurring, because I can't expect for them to be able to change it if they don't even know it's happening. So that's step one in therapy. Next, it's helping develop strategies to improve upon it, which this part can be different for every case, for every person. It's why, you have to kind of do that one-on-one, really get to know the patient and their visual system, but then give them strategies, whether it's, helping to localize better, be more aware of their periphery, but giving them strategies to now improve their visual system that they can then take to their everyday life and start applying it. And then the third part is getting them to the point where they can now do it with distractions present. Because like we said, in life, it's filled with distractions. We've got to be able to get their visual system to a level where they don't have to consciously think about it anymore. So then we start adding in distractions like, can you now do it while you're talking? And we're asking you questions. So there's a cognitive piece. Can you do it when there's balance and vestibular system involvement? Can you do it when there's noise in the background or a metronome beating? Once you can do it with all that extra distraction, then we feel like the skill is really integrated and you're ready to be done with vision therapy. And now we're really lucky in vision therapy that there's a ton of great technology out there. So I highlighted some of the ones that we use in our office. We still love our tried and true heart charts and Brock strings, but this is some of the new technology that really makes vision therapy fun and engaging. In the top left, you can see our therapist on the Vivid Vision unit, which is a virtual reality system that we utilize a ton. It's especially great for patients with strabismus and amblyopia. In the bottom left is our optics trainer, and that one, the patient's eyes work as the mouse for the system. So they're controlling, in this case, it's a little ball moving through a maze, gives the patient a ton of great awareness about what their eyes are doing in space. The middle one is the VTS4 program, which really helps to develop convergence and divergence ranges for patients. Bottom right is the Visograph eye movement test, which helps to map out the patient's eye movements, how often they're rereading or skipping over words as they read. And then there's a comprehension component. And then the top right is the Sanit Vision Integrator, which is a great eye-hand coordination tool. It has tons of other great activities for peripheral awareness. You can add balance to it, and lots of different activity there. And now I just wanted to touch on two case examples to kind of illustrate the points of this presentation. The first one is our patient Grace. And Grace was 7 years old and in first grade when she started vision therapy. Her parents' concerns were that she struggled with attention and concentration, specifically on school-related things. She had low self-confidence, which you'll hear about later. She struggled with reading and she reported double and blurry vision. My diagnoses were convergence insufficiency, ocular motor dysfunction, visual processing delays, and bilateral amblyopia. You can see her refraction down here. She was plus 550, minus 1, axis 4 in the right eye, and left eye plus 450, minus 1, axis 175. And here's a summary of Grace's clinical data. So you can see her visual acuity. We started out at 20/30 in each eye. Her near point of convergence was receded at 6 and 10 inches. She reported double vision during any of the fusional range testing I did, and she had reduced stereopsis or depth perception. She also had really poor eye tracking when we did the initial assessment. And when Grace graduated, she was 20/20 in both eyes. Her near point of convergence was to the nose. You can see how strong her convergence ranges were, and she had excellent depth perception. She also did a great job now with tracking, even when I threw all my questions at her, and her accommodative system was much more developed and flexible. And while that information is really important and the data is great, way more important to us too is what Grace is noticing in her everyday life. And before I touch on that, this is also Grace's visual processing testing. You can see across the board, she was 7 when she started and everything's scoring at a 4 to 5-year-old level. And then when she finished she was pretty much at or above age level in all areas. And now this is the important part, like I was saying. So this is a success story. This is also Grace and her therapist, Lauren. So you can see how happy she was on her graduation day, big smile on her face. And this is what Grace's mom shared with me about Grace's case. She said, reading was a challenge when she started, and our snuggle time was full of frustration, anxiety, squirms, sadness, and at times anger and fear. One particular night stands out as I watched Grace hit her forehead and cry, "Why is my brain so stupid?" I was crushed, and what was worse was knowing that she was crushed too. After completing vision therapy, our bedtime snuggles are now just as I had always imagined. Grace is happy and confident. Last week, she even told me that on that day, she felt like the smartest kid in the class. And that is huge. While I love that I gave Grace better depth perception and eyesight, this is what really hit home to me, and I think really changed and impacted her life. She went from really struggling, being super anxious, not feeling smart and confident, to feeling, like her mom said, the smartest kid in the class. And that's going to stick with Grace long term. So that's really what, made me so happy about Grace's case. And then the other one that I wanted to touch on is an adult patient, Reed. So Reed was a patient, he came in with constant double vision following a construction accident. He had really poor balance and depth perception and was overwhelmed in busy environments. He also really struggled with memory. Now, by the time I got involved in Reed's case, he had done a lot of therapy prior with speech, OT, PT, rehab therapies, and mental health therapy as well. And he, still really struggled. He wanted to get back in the workforce. He was a young guy. And because of all these vision issues, it was really holding him back. His diagnoses were post-concussion vision syndrome, convergence insufficiency, diplopia, and accommodative dysfunction, along with visual processing delays. And this I really wanted to show. This is really showing where Reed started. So this was on his initial testing day. The first video is Reed walking in a line, and his balance, you'll see, is really, really unsteady. So you can see why he's struggling so much. So here's the video of his initial ability to walk this line as he's falling and I'm right next to him. And then the next video you'll see, I put some yoked prism, low yoked prism. I think it was 2 base right that I had put on him. And this was immediately after that first video, and I had him do the exact same task. And you can see how stabilizing his visual system with this yoked prism really impacted things. You can see his stability is still taking his time, but not falling over, not tipping. And this was right after that first one that he did. And that's just a little example of the power of really yoked prisms in vision therapy. Now, these prisms we a lot of times can loan out to patients, so he could use this then in his PT and OT sessions and get even more accomplished in those sessions. And eventually Reed worked out of needing these prisms and was able to do this exact task without any prisms at all, and his stability was great by the end of therapy. Now, here's some of his clinical data. So the big things that stand out here are his near point of convergence test. Reed saw double at 3 feet away and then 4 feet to make it single. His convergence was really low. His depth perception, he had none in the distance and 3,000 seconds of arc at near. Really jerky eye movements and poor accommodation. By the time he finished therapy, his near point of convergence had improved to 6 to 8 inches. Convergence ranges much stronger and excellent depth perception, 60 seconds in the distance and 20 at near, and much better smooth eye movements and solid focusing system. And then another huge area that Reed worked on was his visual processing skills. So Reed, was an adult in his 20s, and you can see where his visual processing scores were starting at less than 4 in some areas and a 5 and 6-year-old level. So no wonder he was frustrated, and especially trying to get back into the workforce, this was hugely impacting things and his self-confidence in himself. And then by the end of therapy, he's now scoring way higher, some areas adult and higher, greater than 18-year-old level. And he felt confident now and was actually just about, I think he went on a job interview soon after, or was close to that point by the end of his vision therapy. Now to see Reed, this is Reed and our resident doctor, Dr. Lester. And Reed, his success story, he said, I can now enjoy going to concerts and the grocery store again and be in other busy environments that bothered me before I started. I'd highly recommend vision therapy. It is so worth it. And this really just pulled all of his past therapies together. Now his visual system was stable, and so he really had that confidence again. So that's kind of my presentation today. I hope it was helpful. Here are some of those references about all the different research that is out there. I hope this was something that was enlightening and something you can use in your everyday practice. And if you have any questions, please feel free to reach out, and I will share this back with Dr. Fortenbacher.
Well, that was great, Dr. Pars. Thank you for a fascinating presentation. And for our professional partners and vision care professionals, if you have a patient who has a binocular vision problem or vision-related learning problem, please feel free to refer that patient right on our homepage of the WA Vision Therapy website. There's a schedule and evaluation link right there. This is also true for individuals. If you have a concern for yourself or a family member, you can self-refer. And for you, the viewer, our next episode of the Luminary Program is scheduled to air on May 25, 2023 at 7 p.m. Eastern Time, where the topic will be a systematic approach for identifying and targeting key visual biomarkers in the treatment of post-concussion syndrome. And don't forget, you can stream the Luminary Program from the WA Vision Therapy YouTube channel beginning April 24, 2023, where each episode will be available to everyone free of charge. Thanks for watching.